Hello. As chair of this study and of this committee meeting, I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to examine how our nation delivers, finances, regulates, and measures the quality of nursing home care. The committee's full official statement of task can be found on the project website. We would also like to thank our study sponsors. The committee members are listed on the screen. I would like to remind everyone that this is an information gathering session. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has not made conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. We are also inviting residents, family members, and nursing home staff to submit their stories and experiences, which are also a very important part of our information. Today's webinar will be recorded and archived at the link shown on the screen. I want to note that this is an open, on-the-record session. Individuals from the public have been invited to attend as observers, and we will not be entertaining questions from the floor. Please do note, however, that anyone can submit testimony or other materials to the committee at any time, and these documents will be placed into the committee's public access file. You can submit this information through the project website. Today's webinar will explore a variety of perspectives. We have given each speaker only 10 minutes for their remarks. I kindly ask that we be respectful of this time limit so that we have time for ample discussion with the committee members. I would like to now introduce the moderator of this session, Dr. Deborah Saliba.
Hello, we will be hearing from 3 speakers on nursing home quality today. First, we will hear from Mitzi Daffron from QSource, the Medicare Quality Innovation Network Quality Improvement Organization for Indiana. We will also hear from Barbara Frank, co-founder of B&F Consulting. And finally, we'll hear from Ann Montgomery, director of the Center for Elder Care Improvement at Alterum. More detailed speaker bios can be found in the webinar briefing book on the study webpage. And committee members will have an opportunity to ask questions after all 3 speakers have completed their comments. So let's begin by welcoming Ms. Daffron.
Thank you so much, and appreciate the opportunity to share a little bit with you about the Medicare QIO work in nursing homes. Next slide, please. Just to kind of introduce QSource and who we are briefly, quality improvement is at the heart of what we do, and it has been for more than 45 years. We currently are operating under quality improvement contracts in 11 states, including as the Medicare Quality Innovation Network Quality Improvement Organization in Indiana. Next slide. I wanted to talk just a brief moment about the evolution of the QIO program for those who may not be overly aware. We started back in 1972, and the professional standards review organizations were regional organizations within each state, primarily focused on medical record review, looking at charts, making sure care was provided appropriately. In 1982, we were renamed peer review organizations. These contracts moved to a statewide basis, and the focus remained on medical record review until 1994, when we added the quality improvement component. By 2002, we were renamed Quality Improvement Organizations, and this began the real focus on true quality improvement efforts at the provider level and boots on the ground assistance to healthcare providers. Next slide. So 2002 is where our real work in nursing homes began. We were really focused statewide. We held regional meetings. We had collaborative events. We did provide some individual technical assistance. Initially, our targeted projects were on topics like person-centered care, pressure ulcers, use of restraints, and other topics. We worked with a lot of stakeholders. In Indiana, we worked with all of our trade associations. We worked with the Pioneer Network, and we worked with the Indiana Department of Health. In 2014, our contracts were extended to 5-year contracts. Before that, we operated on 3-year contracts, which didn't give us a lot of time to really get things going and show improvement. 5 years allows us time to initiate, implement, evaluate, and sustain change. Next slide, please. So a little bit about some of the impact that we have seen. Between 2014 and 2019, which was our previous contract period, QSource coordinated a partnership known as the ATOM Alliance. We were the QuinQIO for Alabama, Indiana, Kentucky, Mississippi, and Tennessee. And some of the improvements that we saw in nursing home quality, we saw nursing homes improve their composite scores or their quality measures. We saw a significant improvement in reducing the use of antipsychotic medications, which meant fewer nursing home residents were on unnecessary meds. Next slide. We also saw fewer urinary tract infections. We saw fewer residents reporting moderate to severe pain. And we saw fewer residents with catheters, which reduced the chance for infections. Next slide, please. So our current QIO contract started in November of 2019. It focuses on small, which is defined as less than 50 beds, rural, and or low-performing nursing homes, which are defined as 1- and 2-star facilities. We're also, as you can imagine, working with additional facilities due to COVID outbreaks. We're currently working with 483 of the 534 nursing homes in Indiana, and 100 of those nursing homes are receiving intensive technical assistance with infection prevention programs. Some of that assistance includes review with the nursing home of their infection prevention and control programs, giving them feedback, helping them make adjustments and improvements to their programs, conducting compliance audits, and observing staff compliance with things like hand hygiene and use of personal protective equipment, and assistance in putting together infection control binders and antibiotic stewardship programs. Next slide, please. Our nursing home team, which by the way is 3 people, has made on-site visits to 102 nursing homes since September of 2020, helping with COVID-19 outbreak control and prevention, and helping them respond to state survey detailed plans of correction. We obviously have been partnering very closely with our nursing home trade associations and the Department of Health through this so that we're all sending the same message to our nursing homes. Next slide, please. So I wanted to just share some best practices of some of the things that we've been doing. We're not just a source of information. We don't just email resources out and say, here you go figure it out. We're providing assistance in actually implementing those resources. So a real life example, March of 2020, one of our nursing home team members was on site with a nursing home, helping them develop and put an infection control system in place. 3 days later, COVID hits. The system that they put in place allowed them to easily track and document infections. It allowed them to not have to focus on that aspect as much during COVID. They already had it in place. We actually returned to that facility a year to the day, not planned that way, but in March 2021. And this facility was very quick to tell us that they received no infection control tags during the pandemic, and they were complimented on their infection control program by the state surveyor. Next slide, please. Some additional best practices. We share tracking tools and provide training to nursing home staff on how to conduct audits, how to use the tracking tools, how to look at their data and where they are in their processes, where they can improve. We provide assistance in developing antibiotic stewardship programs. I will say that an overall best practice is hands-on support, developing those trust relationships. Again, not just handing them something and letting them figure it out, but standing side by side with them and helping them implement best practices. The comfort plan menu is another tool that has been very well received. It provides options for comfort care beyond pain meds. And we have seen decreased opioid use in facilities that are using this comfort plan menu. Next slide, please. So ongoing work. We're expecting a contract modification shortly. We actually expected it before now, but we do know that there will be a heavy focus on infection control and prevention, but we're also going to be looking at immunizations, including COVID vaccinations. We're going to be looking at reducing adverse drug events, decreasing hospital readmissions for facility-acquired infections, decreasing preventable ED visits, and avoidable readmissions to the hospital. Along with that, we'll be reviewing and providing assistance with implementation of emergency preparedness plans for our nursing homes. We do provide support through data. They have access to monthly CASPER reports. One of the things that we are doing is providing through a secure web portal, we're providing their data with trending so that they can see over time how they're doing. If they did well at one point and then maybe they fell off a little bit, or maybe they're doing better now, and they can kind of look and see what they're doing differently, what they need to do differently. We also give them comparisons to the rates in their community, the state, and nationally. Next slide, please. So the future, we need to focus on sustainability through simplified processes. Our nursing homes are overwhelmed with information, especially with COVID. They've been inundated. They need the pieces on how to sustain their efforts and not be running from fire to fire. Staffing, I don't need to tell you all this. It's always been a concern, but with COVID, the impact has exponentially grown. Nursing homes are losing staff just every day. And it's not just CNAs, it's not just dietary, housekeeping, or floor nurses. It's administrators and DONs. And they're not just going to another nursing home down the road. A lot of them are leaving healthcare altogether. Our assistance will continue, as far as we know. Development of relationships and that trust factor is crucial in that. And we're going to be gearing our assistance to multiple levels of nursing home staff so that when people do leave, it helps alleviate the impact and loss of the complete knowledge base. We do believe that nursing homes need that non-punitive assistance that the QIOs can give them, in addition to the required regulatory system. The next slide, I believe, is just my contact information. The next slide has some of the ways to connect with us on social media. I know we'll have some time for questions later. So at this point, I'm going to end my comments and turn it over to Barbara Frank.
Good afternoon. My name is Barbara Frank, and I'm humbled to testify before you. So many of you whose work has taught me so much. Humbled by your enormous responsibility and by your request that I reflect on what has and hasn't worked over a lifetime dedicated to bringing the promise of the Academy's 1986 report to fruition. We've come a long way since Elma Holder and I, with the National Citizens Coalition for Nursing Home Reform, brought nursing home residents to a national symposium where they told committee members what was most important to them: kind, caring staff who helped them be themselves. While the field has changed dramatically since then, the central language of OBRA 87, attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, is abiding. Individualizing care still leads to better outcomes. Combining frontline staff's knowledge of residents with clinical expertise gets you to those better outcomes. And when leaders take good care of staff, staff will be able to take good care of residents. In times of crisis, nursing homes pull through better when everyone pulls together. When COVID hit, one leader told her team, "Let's be careful, not fearful." She told them, anytime you have a question, a fear, you're unsure, call a quick huddle to check with others. And she said, that's what got them through. Over decades, we've had bursts of widespread adoption that have moved the field forward. State coalitions provided joint training after OBRA's passage, Untie the Elderly, the Pioneer Network in Culture Change, the St. Louis Accord, Advancing Excellence, the recent campaign to eliminate inappropriate use of antipsychotic medications. All of these changed practice. They all worked because there was common ground and a concerted effort. DONs and administrators, state surveyors and advocates all came to a new understanding together and learned together how to change their practice. A member of your committee asked me to address what has prevented widespread adoption of these proven leadership practices. Well, there's actually a lot of good leadership out there. We see DONs and administrators pitching in, checking in on people, involving their staff. Amazing, courageous leaders who have worked day and night through COVID, as they do through hurricanes and snowstorms. However, there's very little that reinforces these instincts, a lot that drives against them. The pull to stay within the boundaries of corporate policy and the fear of survey deficiencies reinforce the status quo. These leadership practices are fragile. Someone in charge has to believe in them, and once that person leaves, everything goes back to the norm of do this and do that. And the staff who felt human feel again dehumanized. Susan Eaton talked about the intrinsic motivation as a quality among people who work in nursing homes and are driven by their true caring for the people they care for. When leaders ask their staff their thoughts on what is causing the problems and what can be done about it, staff will gladly tell them and be part of the solution. That's the foundational principle of quality improvement. Go to the customer and the employees closest to the customer. So what prevents adoption of these practices? Nursing home leaders study to the test. They follow what their bosses tell them to do and what the survey process requires of them. Regardless of how dramatically you remake the system with your recommendations, as long as these elements remain in play, progress on the ground will be impeded. Most corporations impede innovation and high involvement leadership. The profit motive drives decisions down to questioning an administrator on the food purchase of broccoli crowns. Corporations direct DONs to staff to census and send home staff who came to work. That corporate owners and executives make the salaries and bonuses they do, while their frontline caregivers can't live on what they get paid, that's unconscionable. Corporations have a policy and procedure for everything. When deficiencies are cited, corporate teams rush in to scour the policies and procedures, add new ones, write the plan of correction, train everyone, and leave. It's rare that corporate leaders ask the staff closest to the residents what they think is contributing to the problem and what they think needs to be done what help they need to address it. Instead, they leave staff with one more form to fill out, where it's likely to get skipped over in a few weeks. The survey process breaks down at this plan of correction level. There's no quality improvement process in a standard response of a new process, a new form, training, auditing. Yet surveyors dutifully check off that it's been done Accepting these meaningless plans of correction doesn't solve the problem. Committee members asked the three of us presenting today to discuss best practices in quality improvement work, and my co-presenters, I'm sure, will do plenty of that. But let me just raise a couple issues. First, a concern. QAPI has not lived up to its potential. When the CMS work group first visited nursing homes with high performance, the common ingredient they saw was high involvement leadership. That concept was emphasized throughout the early stages of QAPI development. We watched it transform nursing home practice as leaders trialed high involvement in making change. However, the final QAPI regulations drowned out high involvement with a deluge of mandates for documentation. Most QAPI efforts now are just a paper exercise for the surveyors. As Mitzi said, QIOs work best when they're state-based and they provide training in person and on-site. They know their nursing homes, they know their state. Death by 1,000 cuts has limited QIO's ability to be hands-on, and that's limited their impact. Now on the positive side of quality improvement, there's an emerging initiative that could provide some valuable insights for your committee's deliberation. It's occurring at the VA. Kathy Brady, David Farrell, and I are currently consulting with the Veterans Administration nursing homes called Community Living Centers, or CLCs, through the VA's Quality Improvement Arm CONCERT, which stands for the CLC's ongoing National Center for Enhancing Resources and Training. The VA's Office of Geriatrics and Extended Care is in the early stages of aligning its survey corrective action plans and its VA QAPI to drive individualized care and high involvement of frontline staff. The VA is calling it whole person, whole team. Whole person being integration of physical, mental, and psychosocial well-being. Whole team means integration of the knowledge of the staff closest to the veterans with the clinical expertise of the rest of the team. While it's premature to talk about results, I encourage you to keep an eye on what is happening. It may serve as a laboratory for how CMS might improve its process for plans of correction and improve its QAPI. Your committee member asked me to recommend 3 major changes for the nursing home industry to fundamentally improve fundamentally accomplish improvement in quality of care. First, keep the core statement, highest practicable well-being, as the aim. Between the original regulations and the update in 2017, we have much of what we need in law, regulations, and guidelines. I endorse so many of the recommendations for improving staffing, quality, and environment, but I'm going to focus my recommendations here on ways to implement any requirements. 3 levers of government have great influence with plenty of room for improvement: financial accountability, the survey plan of correction process, and hands-on QI. The 4th lever, persistent advocacy through the Long-Term Care Ombudsman Program, needs sufficient funding for its enormous responsibilities. So for recommendations, 1, financial accountability. Don't let the profiteering corporations continue to get away with shortchanging staff and providing poor care. Require a living wage and benefits, including paid time off for all staff working in nursing homes receiving public funds. Use a pass-through with stringent audits. Require consistent assignment for nursing assistants and nurses and 24-hour RN coverage. When data shows a nursing home has high turnover and low quality, make them pay their staff better, treat them better, hire enough staff to do the job, and use consistent assignment. If a corporation has a pattern of poor practices, hold them accountable at the corporate level and apply remedies to all their homes. Don't let corporations with a poor track record get new provider agreements to run more homes. And the survey process. Make real plans of correction. Use timeframes and guidance that drives leaders to ask staff and residents about the root causes of problems cited and to participate in developing realistic on-the-mark solutions. And fund survey agencies and include sufficient pay and benefits and training for surveyors. In terms of quality improvement, restore the emphasis on high involvement to QAPI and return state-based QIO programs to in-person on-site consultation. We've come a long way since 1986. We have a long way still to go. However big you dream about what a better system looks like, it's only going to work as intended if we tackle the corporate influence and make the survey process work through real plans of correction. With that, perhaps we can reach the promise of highest practicable well-being for each resident. Thank you, and good luck with your important work.
Wow. Hi, everybody. I'm Ann Montgomery. Those were two very splendid presentations. I'm director of the Center for Elder Care Improvement at Altarum. I have the pleasure of knowing many of you personally, and I'd really like to thank you, as the other panelists have, for doing the work that you're doing here. It really couldn't be better timed or more important. The nursing home industry is definitely at a crossroads, and so are policymakers. And I'm also very honored to be here with Mitzi and Barbara. So I'm going to start by channeling the voices and the perceptions of nursing home residents, and I'm really glad that you're collecting stories. Altarum is a research organization that does a lot of work to try to improve nursing home quality, and we have a 3-year comprehensive culture change project operating right now in Michigan, where we're headquartered. And after COVID-19 hit, and once the doors closed to the outside world, we knew how important it was to reach actual nursing home residents in order to find out what they were experiencing. So basically, we devised a way to do a rapid online survey with no external funding. We're very motivated, and happily we have some very good survey researchers in-house. And to distribute it, we asked colleagues, provider associations, ombudsmen, advocates, and others to help us disseminate an online link. We left that up for 6 weeks, and fortunately our novel method worked, and we received 365 responses from 36 states. The questions that we designed were aimed at finding out how residents perceive their lives, both before and after COVID. How safe did they feel? What was their quality of life like? How are they coping? The answers we got back were not upbeat, and here's a quick sample. I have become anxious and depressed due to the separation from my loved ones. I have little appetite and am losing weight. If the virus doesn't kill me, the loneliness will. I feel like I am in prison. Now, not all residents said they were in despair, and quite a few commented on how hard nurse aides and nurses were working, and they were very appreciative of that. But despite those efforts, residents made it very clear that the physical isolation that had been imposed on them was unbearable, because they know they are in the last years of their lives. Worryingly, residents also noted the staff was lower during the pandemic than before it, and I think we've heard a little bit about that. And since we know that low staffing is associated with poor quality, that's very troubling. So basically, staffing has gotten worse at precisely the time that it needed to get better. And taking a pause, really, or a note from the age-friendly health system, ultimately, I think what we found is that the survey helped to illuminate that what matters most to residents is a good quality of life. And I hope that this remains front and center for everyone who is thinking about reforming and reimagining nursing homes, which I know you're doing. Here's how one of our survey respondents put it. I want visitors to be able to come inside to see me. I don't want to be restricted to my room all day and night. I want decent food and to have access to it. I want to be able to walk outside of my room and see my friends and family that I usually see daily. I want to regain my strength, better quality of life and independence, and I want to be informed regularly about what the facility is doing and what is going to happen. I want to have my rights restored. I want to have the freedom to come and go like everyone else. I think that what this expresses is when you're old and you need help and you're living in a nursing home, then that is your home. Nursing homes really have to recognize and embrace this truth and redesign and reprogram how they operate in order to produce a genuine feeling of home for long-stay residents. Almost no one, after all, really wants to live for any length of time in a hospital or a hospital-like environment. Probably the best physical manifestation of innovative thinking in the design of nursing homes are small houses, which the Greenhouse Project and others champion. Effectively, the Hill-Burton Act imprint on nursing homes should be erased in this decade and in the next, with a wave of rebuilding and renovation of older buildings if we can pull that off. The point is, we need to be deeply creative and open to new ideas and work to design long-stay residences that are actually delightful. And hopefully, many can be in the center of towns and communities and not generally removed to a segregated campus where only older people live. But the physical environment is not the only thing, as we know, that needs to change. We have to clearly define and insist on excellent staffing, and we've been talking a bit about that already, and I'm sure we'll talk more about it, precisely because it's fundamental to quality of care and quality of life and safety. There are many ways to accomplish this, and they will take time and effort and money. Primary among these are new requirements for much better training and educational and career advancement opportunities for direct care workers. I think it's kind of bizarre that CNAs are often equated to fast food workers. It really makes no sense. First of all, as a matter of equity, this is unfair to women and persons of color and immigrants who comprise most of this workforce and deserve as many opportunities to advance as anyone else working in our healthcare system. And second, deliberately keeping long-term care workers at the bottom of the economic totem pole will inevitably mean that quality will be lower than we would like to see it, and turnover will remain very high. Temporary nurse aides and strike teams are not permanent staffing solutions. Instead, we need to build a workforce of many more well-trained CNAs and home health and home care aides to provide critical supports in our now very rapidly aging world. So how do we get there? Along with career opportunities, we must raise wages and improve benefits for nurse aides, and this has been recommended by some researchers and by many advocates, including those here today, for years. A recent study published by Leading Age called for wages for direct care workers to be set at the living wage level in each state by 2022. If that happens, and perhaps it will, since Congress may provide a lot more funding for the long-term care workforce as part of the infrastructure package now being shaped, 3/4 of aides would see a significant pay increase. And wage increases mean that turnover would likely decrease as well, and we need that data. 12 years ago, I had the privilege of working on nursing home policy as a staffer for the Senate Special Committee on Aging. And one of the provisions that we wrote, Section 6106, was enacted as part of the Affordable Care Act. A few years later, that became the payroll-based journal system, and PBJ is a very valuable database, but the job is not yet done. Rather surprisingly, although the ACA clearly directs the HHS secretary to include turnover and tenure in reporting, this is not yet required. It should be. I am a believer in the power of the federal government to do important things, and this is one of them. So let's get this done, and then we can stand back and look at how high turnover really is across the country in every home and what we can do about it. We're also overdue for defining what sufficient staffing is too, because that is the word sufficient that was written into federal law in over 87. I don't believe there's ever been a quantitative standard attached to that word that really defines it, but the evidence is there for defining what is sufficient in the form of a comprehensive study published by HHS 20 years ago. Although that study, like any other, could undoubtedly be refined and updated and improved in certain respects, the central finding remains quite important, which is that the threshold below which quality problems begin to manifest is 4.1 hours of care per resident per day. This should be the baseline expectation, the norm, if you will, for defining what sufficient staffing is. Beyond that, we can have discussions about adjustments for resident acuity and other factors. And that leads to the broader question of accountability of the nursing home sector at the federal level, at a national level. And I think Barbara was touching on this. To strengthen accountability across the nursing home sector, we need a mechanism, a directive, perhaps an executive order, to pull together the various oversight efforts and monitoring and enforcement authorities of CMS, the HHS Office of the Inspector General, and the Department of Justice, to look not only at survey and certification data, but also at staffing data, including turnover and tenure, ownership data that resides in the PACOS database that is within CMS's purview, cost report data from Medicare claims, perhaps other data, whether that's QIO or certain MDS-based quality measures, complaint investigations, or something else. When these data are assembled and analyzed together, when the dots are connected between different measurement and data systems and the accountable parties, owners, and those who have a financial stake in a home or a chain or a group of homes, then conversations about who needs to fix serious quality problems or a serious financial problem become much easier to have. Finally, we need more accurate information for consumers who are trying to understand which nursing home is their best option. The 5-star rating system was and is a good idea, but it's not doing quite as good a job as it could, and it needs a refresh. For consumers, the basic expectation should be that any and all nursing homes listed on the government's website are safe and that they provide good staffing and good care. We expect the planes that we board to be safe and the flight to be a reasonably decent experience. We know that the risk that the plane will crash is not zero, but it is very small. In a similar way, we should have consistently high expectations for nursing homes for safety, for quality of care, and for quality of life. We should not keep making the mistake of continually tolerating systemic failure. We need better standards that are evidence-based and that are part of an ongoing, never-ending process of monitoring, of measurement, and of quality improvement. We need to view nursing homes not only as buildings that house Medicare and Medicaid beneficiaries, but as organizations that are striving to exemplify a high-quality model of residential long-term care. In closing, and along these lines, here are 3 quick additional ideas for consideration. First, we could think about making staffing the central pillar of our 5-star rating system, and we could make it a lot clearer to consumers whether staffing is actually sufficient in any given home and what the training of aides encompasses. 2, we could include a summary description on Care Compare of whether a given nursing home is pursuing culture change, which prioritizes person-centered long-term care and a good quality of life experience. Resident choice and resident experience, as many of us know, are central to culture change, and they are not thought of as somehow optional or less important than clinical and supportive care. We should capture best practices on how nursing homes can deliberately cultivate a strong sense of community, of relationships between residents and between residents and staff, of warmth, of life. And we should ask CMS to work with the Center for Medicare and Medicaid Innovation to implement Section 6114 of the Affordable Care Act, which authorizes a national demonstration on culture change in nursing homes. No one objects to this, so let's make it a priority. It's a powerful mechanism for infusing quality improvement into the nursing home sector. We should ask all nursing homes to survey their residents perhaps once a quarter to find out how things are going, not just whether they are satisfied, but what their experiences are, whether they have meaningful choices about what they do day to day and what can be improved. As a simple example, during COVID-19, our survey found that residents would benefit from online programming. Many said they had access to Wi-Fi and to tablets or computers, and that's promising, but there was not a lot of attention being paid to curating interesting online experiences. We can change that. We can measure it, and we can report it. As Buckminster Fuller famously said, you never change things by fighting the existing reality. To change something, build a new model that makes the old model obsolete. I second that, and I hope that this has been helpful. Thank you again for your time and attention. I'll submit this in writing, since the written version has some links to some possible executive orders, which if implemented, I think would do a lot of good in buttressing accountability.
Thank you, Anne. We appreciate your comments today. And in fact, I want to thank all of our speakers, Mitzi, Barbara, and Anne, for some amazing insights that you've given us today, and the important work that all 3 of you guys are doing to improve quality in our nursing homes. I want to open the session to questions from our committee members. And members are reminded to use the raise hand function so that we'll know you want to ask a question. And I just got a hint from Nikita that if you use Alt-Y, that lets you get directly to the raised hand. So I know that we have a question from Mary Arsek. Mary?
Thanks, Deborah, and thank you to our 3 speakers. As someone who has been doing clinical research and quality improvement in nursing homes and also the VA for many years, I realize, I certainly know firsthand how difficult this work is and yet how really rewarding it is. And I appreciate the comments to stay focused on quality of life, and I heard a lot of emphasis on workforce, and I couldn't agree more. I had a question about specific quality improvement strategies. Since COVID, there have been the proliferation and funding of various strike teams in each of the states. In my own state of Pennsylvania, these are often collaborations between healthcare systems, often academic medical healthcare systems, and a group of facilities. And we also have the IHI ECHO model. I think prior to COVID, I think I could say that with few very notable exceptions, academic healthcare systems and health science schools haven't been that focused on nursing homes. There are notable exceptions, including among this group of our committee, but in general, no. And in the 1980s, we had teaching nursing homes. Those kind of went by the wayside. And so I'd like to ask our panelists, What opportunities do you see resulting from these new partnerships among, academic and healthcare systems, QIOs, and partnerships with various facilities across the country?
I can take a stab at that. At least I'll start and then others can chime in. That's a wonderful question, Mary. And we have actually been working very closely with our Project ECHO teams here in Indiana throughout COVID. We're part of several of their cohorts, provide weekly feedback to them from our on-site visits in nursing homes, telling them, what we're seeing, maybe what we should focus on, where do we need some education, those types of things. So I think, there's a partnership that I hope will maintain. Our Project ECHO has been run through Indiana University and Parkview Health System with some other partners that came along and ran some of the cohorts. So I think, the strike teams, those were very early on. They were going out before QIOs were ever tasked with going on site to the hotspots. And we have literally been on the phone with our Department of Health talking about what they're doing, what's going on. For months, it was daily. At this point, it's probably 2 or 3 times a week. So those partnerships are there. I hope they continue at that level. But there's definitely a lot of coordination that can happen among those groups.
I'm going to move on to Ann, go ahead. I'm sorry.
That's okay. I was just going to add a word that we at Altarum at the Center for Elder Care Improvement have the honor of collaborating with some wonderful culture change organizations, the Eden Alternative and the Greenhouse Project. And what we're doing is essentially 3-year, what we call comprehensive culture change projects that aim to embed, a lot of the quality improvement that we're talking about and that QIOs are also doing, and effectively begin to shift, the tools, the measurement, the feedback to nursing homes in the process of doing those 3-year projects, and then take that forward to the national level where we hope CMS will be persuaded to do a national demonstration. So that's really the trajectory that we're on, and we've applied in a couple of other states. And we look at clinical quality measures, including antipsychotic use and depression and hospitalizations. We look at economic impact. We spend a lot of time on quality of life. By the way, you can use quality of life data that we collect in QAPI initiatives, which is an interesting thing. And we also do focus groups and interviews. So we're really trying to build an evidence base that sweeps up everything that everyone else has been doing for the last 40 years into kind of an organized framework for taking it forward, and certainly hope to be working with the QIOs and with Barbara soon as well, because it's really possible to do this work. It's just, it's ongoing. It sort of never stops.
Thank you. We have several hands raised. If you don't mind, I'm going to move on to the next question, and then we can loop back to this topic if folks would like, if we have time left over. Jasmine Travers.
Thank you, Deborah. Thank you to all of our panelists today. So for me, both Mitzi and Ann discussed the work QIOs are doing with tremendous impact on nursing homes related to quality of care and implementation of best practices. And Ann did bring up the need for these organizations to be state-based and incorporate in-person training. But can you all help us understand the reach of the QIOs, the limitations, and what is needed to get these resources to more nursing homes, and with the intention of improving the necessary areas related to quality of care?
Well, what I'll say, number one limitation is money. Honestly, we have found that we can do a lot in the nursing homes. During COVID, this going into the hotspots, I mean, it was just incredible the amount of work that we could accomplish there. We're just, you know, we're not funded to go into every nursing home. I mentioned we've got 534 just in Indiana, and we've got 3 people. It's, you know, it's not feasible. Also with, and Barbara can probably address this too, but with QIOs right now being kind of regionally based, not every Quinn QIO has boots on the ground in each state. Some of them have taken a virtual approach. You know, so in my mind, that's kind of a limitation too, but again, it was related to funding and how much funding they had to do that. So we have the expertise and the knowledge to be able to do it. We just don't have the resources to be able to do it at that level.
I'd like to chime in about that as well. You know, when it was so helpful to have Mitzi give that history and to look at from 2002 to 2005, the QIOs were and for the next scope of work after that, the QIOs were funded to go on site to nursing homes. They were in individual states. They would bring people together regionally. And one of the things that I always keep in mind is that the nursing homes who have a lot are pretty solid, go to the trainings. You know, the ones that are good keep on getting better. The ones that are struggling every day that don't even have the staff that, you know, the administrator signed up for the meeting, he means to go, but he's washing the windows because the housekeeper quit. And there, you know, we've been in meetings where the administrator had to leave the meeting to go and stop an abusive boyfriend from stealing somebody's paycheck. It's like when this is going on, you have to be on site. And so if you really want to focus on the homes that have the most need, you have to put the resources into going to them. The other thing is that most nursing homes don't need to be convinced. They need the how-to. And so in a webinar, you know, that stuff just bounces off. It's very well put together. It's very well meant. People that have a solid situation can grab a hold of it. People that have an unstable situation, it's just going to bounce right off of them. So if you really want to target the people who need it the most, you have to go to them.
Thank you.
I'm gonna move to the next question. Phil Sloan.
Thank you. This has been a great discussion, and thank you all for your presentation. It's been a lot of great ideas. I'm really getting you to think about, you know, how do we reconcile the quality measures, QAPI, QIOs, the quality of life, you know, kind of putting that all together, you know, because I've heard I've wondered where the QIOs have gone. And I've wondered about whether, you know, all this QAPI stuff has anything to do with quality of life for residents. So I'm going to ask a focus question because I think the others have talked about some of the things already. And that is, you know, it's so easy to do projects in facilities that are easy to work with. And that means that the ones that need it the most don't get the attention. Considering the QIOs are never going to have enough resources, would it be helpful to mandate them to only work with, for example, the special focus program facilities, you know, or the ones that really need us, or would that just be another idea that wouldn't work?
So we actually, in this contract, CMS gave us a list of what they call eligible nursing homes. And those are those rural and low performing. So that's those 1- and 2-star facilities or the small facilities. Now, I think where the disconnect is you can't assume that rural and small facilities are low performing and that they need all the help. A lot of times those are at the top of our list. Those are some of the better ones. But because they're rural and small, they get kind of lumped into that group. We totally agree. We would love to just be able to focus on those that truly need our assistance. I mean, we have nursing homes that we've worked with since 2002. I mean, they've been, in everything that we've done, and they do well. We have some we just honestly haven't been able to do a lot with, because they don't have the time, they don't have the resources, and it would be good to be able to get in there.
You always need to have front runners, and you need to move the middle of the pack. And you need different strategies for, front runners are going to hear an idea and they're just going to demonstrate it. But the middle of the pack, when you move the middle of the pack, you're learning the how-to. It's practical. It's realistic. You can't just say, oh, well, they have all those resources that they can do it. And so I think the QIO's role in moving the middle of the pack is absolutely essential. There has to be a different strategy for the folks that are struggling the most and can't grab a hold of it. And there was funding in the first cycle in 2002, the second cycle in 2005. And I think it was late 2008, maybe in that next cycle, that it started to get cut back. And then it moved to the regional, and it was death by 1,000 cuts. But I just want to throw in two more comments really quickly. One being that for me, talking about quality of life as if it's separate from quality of care misses the point, and we pit against each other. All of us who have ever had any kind of medical experience know that when the medical person treats us individually and applies the medical advice to our reality, we're going to do better. And that's what those two go together. And the last thing I just wanted to say about emergency preparedness is that we saw this with Katrina, where the emergency preparedness system ignored nursing homes. They talked to the hospital system, but they ignored nursing homes, and we saw this with COVID. And I think a strong recommendation from you all saying nursing homes are part of the healthcare community and need to be included in those plans, included when PPE is being given out, included when you're thinking about allocation of beds. So thank you for letting me riff off of Phil's question.
And
And I'll
Anne, I
just
think
chime
you
in.
want.
Oh yeah, I'll just chime in and say that I guess I'm an optimist, but I think that quality improvement, it starts wherever a home is. We basically meet homes in our comprehensive culture change projects where they are, and we haven't yet worked with a 1-star home, but we have worked with 2- and 3-star homes and 1 5-star home. Interestingly, the 1 5-star home that we started working with decided to drop out. But everybody can make progress. The point is, where do you want to make progress? You have to be motivated. You have to want to do it. You have to sort of listen carefully to the training and the coaching and the mentoring, understand what the relationships are between changing your daily routines and being able to do that, to track them, and to see if it becomes more person-centered. You can rate yourself as staffers, and then the residents also need to rate you as to whether it's really meaning something for them. So we find that actually some of the more unexpected homes, sometimes make the biggest progress in the work that we're doing.
I think almost all homes are motivated, but a lot of times they signed up for something and they can't get out the door, or corporate calls and says, hey, I demand that you do this or that. And so I think we have to look at what impedes people, and very rarely is it that they don't want to do a good job.
Thank y'all. I'm going to move to the next question because we have several folks that want to talk to y'all. David Stevenson.
Yeah, I'll go quickly since we're short on time. Thanks to all the speakers. This has been great. So Barbara, you mentioned a few things like fear of deficiencies impeding progress, or excessive layers of documentation, undermining plans of correction. My question for you, and others can chime in, is how compatible or incompatible are quality assurance and quality improvement? In other words, what role should survey agencies play in quality improvement, if any?
I think that the carrot and the stick are both needed, and that they should have a separation line, so that enforcement needs to be enforcement, quality improvement needs to be quality improvement. However, they should not run against each other. And the way that we carry out our enforcement is contradictory to quality improvement. So enforcement should be enforcement, but it should, if we're saying that the way to find out what's going on is to go talk to staff, then you don't sit in a conference room and write a report and change your forms and have that be accepted. Any one of you could just look at randomly a plan of correction, guarantee those are the elements of it. It's like I'm sure you get taught that somewhere in survey correction school, and we accept that. That's unacceptable. So I think the two should be separate, but I think that the survey agency should practice quality improvement in its expectations of how somebody improves.
I'll just chime in and say that I agree with that. And I think that they're equally important and they are different. And I'm reminded that the quality assurance and performance improvement program for nursing homes didn't exist until we wrote it into the Affordable Care Act. And that was a mistake, if you will. I'm glad that we've corrected that. And I take Barbara's comments on how we should improve quality to heart, and I think we can. So, nursing homes can always get better, and they should always strive to do that. On the other hand, there are standards that we should hold them accountable for, and if they don't meet them, then there should be consequences. So it's just both. I think the surveyors should understand quality improvement and should be, respectful of it and encourage it, but that's not their job.
Okay, we are really have like 1 more minute left. Betty, can I ask, call on one more person, or should we go to wrapping up?
Let's go for one, unless Tracy or Lori
Okay.
shuts us down.
All right, Marilyn Rance.
Thank you. I had a fast question for Mitzi. The qualifications of the people that you have doing on-site visits. Tell me about that. How are they prepared to build those relationships with staff, and what's their clinical background?
Both of them are RNs. The ones that have done the on-site. I have a third that is a social worker that provides a lot of support, but she's not the clinical person. Each of the 3 people have an average of 20 years in nursing homes. They have been everything from, some of them started as CNAs and worked their way through nursing school. So it's their heart. I mean, that, I can truly say they have a passion for working with nursing homes. And for the residents, they have been everything from administrators, DONs, MDS coordinators, wound care coordinators, infection control. They've run the gamut, and that expertise is what translates when they walk into these nursing homes.
Thank you.
I'm going to have to interrupt, sure. And I want to thank all 3 speakers. This has been, obviously, from the questions, a very stimulating and helpful time that we got to spend with y'all. So I want to thank you again and hand it back over to Betty.
Thank you, Dr. Saliba, and to our panel for addressing so many critical issues. I would like to remind you that everyone can submit resident, staff, and nursing home staff experiences, as well as watch the recording of today's webinar at the study website. I'd also like just to thank everyone who took the time to be with us today for this session, as we all try to address this important need to improve the quality of care in nursing homes. Thank you so much for being with us.